Hi, my name is Sarah Rooney. I'm the Hospice Volunteer Coordinator for Visiting Nurses Hospice here in Lawrence, Kansas. If you are viewing this, you are either a new volunteer and are viewing this for training purposes, or perhaps you are curious about volunteering and just want to know a little bit more about hospice and our volunteer program. I will be reading through this, so it will be paced to my voice. I will add a few things, but otherwise, for the most part, it's really something that you can go through and read if you would prefer, but I will be reading along with you. In this next section, we'll be just visiting nurses and learning a little bit about their history very briefly, about our volunteer services, some frequently asked questions about hospice, how the hospice program works, our services under the hospice benefit, and our hospice team. All of those will allow you to know a little bit more about how hospice works, so if somebody asks you about it, you will feel educated. Next. This is just a brief history of visiting nurses. It started in 1969 with Lynn Rothwell. Her and a group of community leaders formed the nonprofit. It then opened its doors in an unfinished basement, so it was very small at the time. At some point, they incorporated in 1981 with the hospice care of Douglas County, and they merged programs. So now Visiting Nurses is actually a home health and hospice agency, nonprofit, mostly local, although we do serve surrounding areas like Eudora and Baldwin, places like that. Our services, the thing you do need to know about Visiting Nurses, since you will be a hospice volunteer, is we provide things other than hospice. Like I said, home health, rehabilitation. We also provide help at home called private duty, as well as the hospice care. And I'll give you a moment if you'd like to read the mission and values. And all of this also can be accessed on our website at www.kansasvna.org. These are just some basic questions and answers about hospice, so that you feel like you're a little bit familiar with the philosophy and the program. A lot of this will be reviewed again in your training, or perhaps with me if we do an interview. I'm just going to read this one to you. What is hospice? It's a philosophy of care designed to provide comfort and care and support to patients with a life-limiting illness who no longer desire cure-oriented treatments, or when no other treatment options are available. Hospice focuses on palliative care, which is comfort care, which is helping patients achieve physical and emotional comfort so they can concentrate on living. Hospice is there to provide a variety of services in the patient's place of residence, be it in-home or in a care facility. We treat the whole person, physically, emotionally, and spiritually. Those who qualify for hospice will qualify under the Medicare, Medicaid benefit, or they also may be using their own private insurance. They must be diagnosed with a life-limiting condition. Another one would be patients desire comfort care over cure-oriented treatments, so they can decide that for themselves. They don't necessarily have to be told they have a certain amount of time to live if they've decided they no longer want to pursue cure-oriented treatments and know they have a limited lifespan. They also need a physician's referral stating that the patient has about 6 months or less to live. Something to note, though, is we do have patients sometimes on hospice for 2 years or more if they can continue to be approved. Hospice is best chosen earlier on. If you ever want to go off hospice, you are allowed to do that. And patients must have a doctor's referral, so it's always important for the patient to pursue that before deciding to go on hospice. But at any time, any staff can talk to a family about it without them having to apply. Who pays for hospice? It is no out-of-pocket expenses. It is paid in full by Medicaid or Medicare, and most private insurance companies also have hospice benefits. Some of the services, well, there are services that are provided by hospice as part of the benefit. These include physician services, medications, medical equipment, hospice nurse, home health aide, hospice social worker. Also, spiritual care, bereavement services, and volunteer support are all part of the hospice benefit. These are all things that patients and their families can use while they're on hospice. As I mentioned before, how long can you be served on hospice? You can be on hospice as long as necessary to see you through your illness and death. Sometimes the patient's condition improves while on hospice, so you may no longer qualify for your services. But we can ensure that you have a smooth transition to a different level of care. But if your condition does continue to decline again in the future, you can always be readmitted to hospice. People of all ages may receive hospice, and yes, at any time you may choose to discontinue hospice. We don't force you on hospice. And then hospice supports the whole person. As we said, in a lot of times in healthcare, you may just have a nurse tending to a physical need, or you may have a counselor tending to your social, emotional needs. In hospice, they treat the whole person physically, emotionally, and spiritually. And you will note that by the hospice services that I already listed that are provided to the patient and family, noting that there's social work, there's also spiritual and bereavement care, volunteers, which we will talk about more in detail, also including medical equipment, and you'll see some other things down there about inpatient respite care and continuous care. I won't be going into those into great detail, but just to know that they have even additional services in a crisis situation. And again, on the right-hand side, you'll see all the hospice team members, of which you are a valued member. Hi, we're back. We're segueing now into Hospice Volunteer Basics to learn a little bit more about the Hospice Volunteer Program. Again, I want to remind you that you can always go to our website. It's a great place to go and kind of look over all the services that visiting nurses offers in case you have people asking you about your service or who you're volunteering for. It'll certainly give you a much clearer picture of who you are working for. But here are some hospice volunteer basics that you're going to need to know. We're going to start with the service itself, reviewing the program, the kind of services that volunteers offer, the opportunities, as well as the kind of requirements and expectations we have. We will review, also required by our training, the code of conduct. So you are considered in many ways an employee of Visiting Nurses Hospice, so you will be required to read through the code of conduct and behave as written in there. Our hospice patients and families will quickly kind of go over the varying patients you may come in contact with. And then what is your role as a hospice volunteer? Basic do's and don'ts. I think that that's always very important to just lay that out clearly. And then we do also have a safety plan that we'll go over briefly. The Visiting Nurses Hospice Volunteer Program, usually, just so you know, Visiting Nurses serves approximately 50 terminally ill patients on a regular basis. All of these patients, if we feel the need, are offered volunteer support services. Not all of them accept them, and some only require them once or twice. But I would say about half of those hospice clients will use our volunteer support services at some point while they're in our care. We do consider hospice volunteers part of the hospice team, and they're valued. If necessary, as a volunteer, you're allowed to attend our weekly team meetings, which are called IDG, Interdisciplinary Group Team Meetings. You can sit in on a discussion of your patient to hear some more. Volunteers can also request additional contact with staff who are serving their patient to learn a little bit more, ask questions. This would include their social worker, their hospice nurse, or their health aide. We try to remain very open to our volunteers and bring them into the team. By national mandate, hospice volunteers must provide 5% of the services received by our agency's hospice clients, so that's part of the reason we do consider you a team member and also sort of like an employee. Collectively, our hospice volunteers generally donate or provide about 1,400 hours of volunteer services to our hospice patients every year. Hospice volunteer services, just a kind of brief paintbrush through all of this. There's about 40 volunteers who provide a variety of services. Our hospice patient companion services are the one most often requested by patients and family. This is when you're providing patient visit as well as respite for the caregiver. More often than not, that's in-home, but it also can be in facilities. This is usually the highest volunteer need in our organization and requires the largest time commitment. Our volunteers, they come from a variety of backgrounds. You would be surprised to know we've got retirees, empty nesters, university students, stay-at-home parents, and many people who've seen their family members benefit from hospice care and wish to give back. We have volunteers also with special skills that they can volunteer as requested or as they're able. And they can visit these patients once a week, once a month, as their schedule allows. So we do try to work around your availability and your talents. If there's something special you think you have to give that we don't talk about here in our program, you're welcome to bring that up with me. Here's the many volunteer opportunities that we do presently have. The top one is, of course, the one that is most highly needed. It's our patient companions. We also call it respite for primary caregivers. Generally, you're providing once weekly visits for 2 to 3 hours for a patient in a home or in facility. This can take place generally during the weekday, but it can also be a weekend request. Also, you would be available for maybe one-time or short-term companion requests. We also have weekend facility visits. A lot of students enjoy doing this, where they can dedicate a couple hours out of their weekend to visit our hospice patients at the local care facilities where they are staying. This could be once a week or as you're able. Just make the tour, visit our patients who are there, read to them, talk to them, hold some hands, share some stories, connect with whomever you do, and visit them more frequently if you wish. We actually have some nice little side volunteer bits that we offer. We call it care cuts, but it's hairstylists, male or female, who are able to provide haircuts for hospice patients. Mostly these are in-home for patients who can't get out of the home. It just makes them feel really great. Usually you would be requested to do a haircut 1 or 2 times a month, and you would schedule to do that on your own and visit that patient. Massage is a wonderful way to provide comfort. I myself am a massage therapist, and when I can, I go and provide massage to the hospice patients. Again, we'll just work around what your schedule allows. If it's just a one-time visit every now and then, that's fine. Or if you're available for something more regular, once a week, once every other week, for a patient who could really benefit, we appreciate that availability. Whatever you have, let us know. Music, of course, one-on-one or as a group activity, again, very flexible and very meaningful. We occasionally have people needing handy help, providing some outdoor needs or little simple fix-it needs in the house. It's a limited time commitment. There aren't a ton of requests for that, so if you're able to kind of just be on hand whenever the request is there, and if you can do it, step up. That's another way to provide support. And of course, office support. We have other needed agency requests for fundraisers and envelope stuffing and things of that sort. So if you'd prefer to serve in the office, there's places for you there. And again, if there's something special you wish to offer that isn't listed, please let me know. The requirements, they're pretty straightforward. You're going to do your volunteer application. We can do that in person with a piece of paper, or you can download it at our website. You're just going to click the opportunities link, and then you're going to click volunteer, and you can download it there. I do a regular interview. I'll need references. You'll have to sign some confidentiality and other paperwork, and we do background checks. Usually speaking, you're going to be having to drive from these homes, so you will need your own transportation and a valid driver's license. And we do request a TB test yearly. That is free of charge through us. Again, we'll ask you to attend a mandatory hospice volunteer training, which will be offered every year. You will be able to volunteer prior to that with some additional smaller training, but we do have our mandatory that's a little larger. And then I'll be asking you to send in monthly chart notes. It's basically just keeping a list of your volunteer visit dates and how things went. Expectations. Your role as a volunteer is to provide patient companionship, or some of the other roles we've mentioned, respite to primary caregiver or other services. Patient companions, I think they have a bigger role to play, and they can occasionally be asked to help with light duties in the house, maybe simple food preparations if they're comfortable, or little transportation requests. It's all really depending on your comfort level. A volunteer can also help by being an active listener, allowing sharing, reading, life review. If you're comfortable giving a light shoulder massage or hand massage, that's fine, and also by providing a calm, supportive presence, especially for those patients who are declining. We often call that a vigil, just sitting in the room with them as a presence. As a volunteer, we ask that you meet the patient family where they are with little or no agenda. This is sometimes hard, but we ask that you try not to fix everyone, and that you just try to be as gracious as possible in settings that maybe wouldn't typically be the kind of homes that you would be visiting. As a volunteer, you will not be providing any medical or hands-on care, and you'll need no medical training. But the hospice volunteer will be wonderful training that will teach you some other things that you're going to need in terms of maybe some dementia care, how to connect with patients, how to be an active listener, and we'll talk a little bit about comfort care and the dying process and some other information. There's no required dress code. You don't have to wear a dress or fancy hat, but we do ask that you are appropriate, dress cleanly, comfortable clothing is fine. Make sure not to use heavy perfumes or smoke prior to a visit because patients can be very sensitive to smells. And always remember to wear your identification badge, which you will get if you apply when making your visits. Just a reminder, probably makes sense to you, but you should not be bringing others with you on patient visits. Anyone who wishes to accompany you should visit the Hospice Volunteer Coordinator and sign the necessary confidentiality paperwork. Volunteers will also be expected to maintain a high level of patient confidentiality, which we will be reviewing later in this training. This is our V&A Code of Conduct. I'm going to just leave you to read this for a moment before we go to the next slide. If you need to go backwards, you're welcome to do so. This is our basic V&A Code of Conduct, which you'll be held to. And then a little bit on the patients and families that you're going to be serving. Nothing can prepare you exactly, and at some level there's a baptism by fire that goes into all of this. But in short, every situation, every patient and family is going to be different. Some clients are going to be very communicative and engaging, while others may need to sleep most of the time. We care for older patients with significant dementias, but also young clients who are perfectly lucid. Our clients will come from all walks of life, all family dynamics, and everything varies widely. Most often, your visits will actually be supporting the primary caregiver. Your regular visit's going to give them a break, an opportunity to get some errands done, get outside the house, spend some time with family or friends, attend some appointments. It's also possible that they may stay while you visit to get things done around the house, or maybe even take a nap, but they'll feel better knowing that their loved one's safe in your care. In a facility, you may be asked to companion a patient who is anxious. Maybe they need a little focused attention, wheeled around, redirected, but you may also be asked to sit what we call vigil with a patient who's actively dying if you're comfortable providing that. Visits with our patients in facilities can also be about listening to their stories. You can connect with them on any level that you wish. You may find a wonderful way to connect that we have not even talked about here, but make sure to ask questions about their lives, read to them, talk about pictures. Some placements will keep you pretty busy, but others there's going to be little to do, but provide a safe, comforting presence. And in these situations, just to let you know, it's perfectly okay to bring a book or other activity to do while you are there. Flexibility on all these levels on your part is great, and it's key to a good experience. But I want you to know that we always take your preferences and comfort level into account when placing you with a new patient, and I definitely encourage you to share any preferences you may have. These are the volunteer dues. I will try to be brief, but make sure to read through these in total. Of course, be genuine. Don't try to be a hospice volunteer, whatever you think that might mean. We all connect to each other on different levels, and the people you are serving are just people, and sometimes we get along better with some people than others. You don't have to be anyone other than who you are. Very important to be consistent and letting me know if there's going to be absences, letting families know, because they'll be starting to count on you. Again, letting them know of absences and cancellations, setting boundaries, which we talk about in more depth in training. You'll be wanting to inform me before taking additional requests by the patient family. I try to serve as a mediator, making sure to schedule and be the contact for the family, but you need to let me know if you're feeling uncomfortable with any requests or you're not really sure of your responsibilities. Just let the family know, well, let me check with my volunteer coordinator, I just really don't know. She'll get back with you. That'll be fine. Feel free to take initiative, be creative, offer to do things, share your talents. Share your comments and observations with us. We do want to know, and we will respond if there's something that is important for you to be aware of. Reminding you always, of course, to keep it confidential. And we want to know that you're free to attend funeral services or send condolence card if you wish. There's no real rule or requirement around that. It's whatever you're comfortable with and whatever connection you've made. You will be, by the way, informed of your patient's death by email or phone, and typically those get to you in ample time. There would be that rare occasion that it's a chaotic passing or an email was forgotten to be sent, but typically you're going to get that by email first. Again, do wash your hands. This is the main thing. You're going to wash them coming, you're going to wash them going. Always remind yourself to do this. It's very important. You are welcome to provide light touch, a little hand rub, a little shoulder rub. You don't need to be a highly trained massage therapist to do that, but you do need to remember that all patients don't enjoy a lot of touch, even hugs. If you're a big hugger, don't just run in there and start hugging people. Make sure that they are comfortable with that and ask first. Just kind of test it out. Do feel like you can ask nursing home staff for suggestions about your patient. They may know more than I do at some point. So ask for their help, ask for some ideas that they're good people to turn to if they're not too busy. You also are welcome to sort of adjust basic equipment. Like let's say somebody has their oxygen on and they need it replaced in their nose, or their bed rails need raised, or they want their little feet or legs moved or adjusted, hair brushed, things of that sort. Those things are fine. Do not be adjusting larger medical equipment, condensers or things of that sort that require a little bit more knowledge. Even if they've asked you, you can always just call hospice and tell them that there's a need at the house. You can sometimes, and we're not going to go into great detail right now, we'll talk about it more in training, you can sometimes give medications, but that will be previously known and only if they are already dosed out, like they need to be in a pill box, and the patient is also able to take them on their own. You can't give them to a patient who is not awake and able to take them on their own. And again, there may be occasions that you help with what we call a standby assist. This is a patient who is able to ambulate on their own or with a walker fairly safely, and they may need some help to the bathroom. They may even need a little help getting on and off their briefs. And if you're comfortable providing that, we are okay with it, but you will probably know ahead of time, and if you aren't, you can let us know. These are some don'ts. We ask that you don't offer unsolicited advice about medical issues or play the role of a counselor. Some of you may come as volunteers, as RNs or counselors in the past. Try to pull yourself away from that role and know that you're the role of a volunteer. If you have a special comment or concern or need, just share it with me and I'll share it with the hospice staff and we'll follow up on that. Again, don't try to fix the family. They've been functioning this way for a long time. And again, if you have any family dynamic concerns or anything you're uncomfortable with, please let me know. Don't impose your values, attitudes, beliefs. It's certainly okay to talk about your beliefs, but make sure that they are asking and they are interested, and that is a reciprocal conversation where you're not imposing your own belief system. You can talk about yourself in a regular conversational context, but don't talk about yourself or your problems regularly during visits. The focus should always be on the patient and family. It's very awkward when a volunteer comes in and then tells them all their life problems and all the things that have been happening to them or happened to them in their lives. You need to withhold that during your visits and focus more on the patient and family. And please don't expect every patient to be conversational or interactive through your visits. You're going to need to take breaks. Be intuitive about that. There's quiet times, there's naps. Sometimes patients feel a little awkward. They feel like they have to entertain their volunteers. Let them know that that's not their role. Be sensitive and allow them quiet to sleep or withdrawal as needed. And don't feel you need to have all the answers. None of us do. Don't give medications unless you know you're going to be doing this in advance, as I've already mentioned. Don't fully assist a patient who's unable to stand on their own, and this is different than a standby assist. A full assist would be you would literally have to be helping lift them up out of the chair using something we call a gait belt. So if they are unable to ambulate, like with a walker, you're not trained or required to provide this assistance. You're going to need to call hospice if a patient insists on getting up and is a fall risk. And if a patient does fall, it's okay. Don't try to pick them up. Just call hospice. You will have that number handy on you on your ID badge. Again, don't provide wound care or clean up bodily fluids. We've got a star, which we'll touch on at the very end here. And don't change your cleanup briefs. Now, there may be, for some of you, some very rare situations, mostly previously agreed upon, that might require you to help with a brief change or put you in touch with bodily fluids. In this case, you're going to always remember to wear gloves. You're always going to remember to wash your hands. But in none of these cases are you required to help with these things. You can always call hospice whenever something happens or you're uncomfortable with something or you're not sure what you should do. That's why we're here. It's just sometimes we have volunteers who feel quite comfortable helping in these kind of situations that might pop up. Safety tips. We do take your safety as a high priority, and we only place volunteers in homes we feel are safe, but it's always good to remain vigilant. But please let me know if you ever have a safety concern or you just kind of get a weird feeling while making a visit. I want to know. I'm going to give you a moment to just read through some of these things you might want to consider every time you go to a new place. And we do have a safety procedure. It's good to know. Probably you'll never need it. But when you're visiting, this is in a patient's home. If you feel threatened or there is a threat to your safety, let's say a patient becomes delirious and is hallucinating and becoming very angry and upset, we ask that you remove yourself from the situation. You don't try to fix it. You're going to step out of the house and make sure you're out of the home, and then you're going to call hospice. Again, that number will be on you. We ask you not to call 911 unless you feel highly threatened. The hospice will send staff, or they will call 911 if they feel it's appropriate. We ask that you go ahead and remain outside the home until hospice arrives. Or if you think there really is immediate danger, please leave the property. You do not need to take responsibility to control the situation. You just need to get help. When you're visiting a patient in a facility, luckily there's people there to help you. You're just going to want to step out of the patient's room and alert the staff on duty. Also, it's always good then to just follow up with a call to hospice to inform them of what happened in this situation so that everybody's on the same page. I will try not to read through all of this because it's a fair bit, but as a volunteer, it makes you feel better knowing what's going to happen and when to call hospice. So there's a list of reasons why you would call hospice. I mean, really at any time you can if you've got a question or concern while you're serving a patient, but there's some typical ones, like if a patient falls, if a patient is obviously complaining of unresolved pain or becomes extremely agitated, if they're showing significant physical changes, which we will look into in more detail in the training. If the patient won't respond to your attempts to keep them seated and they will fall, if you believe a patient is actively dying or has just passed, or if you feel threatened, those would all be very good reasons to call hospice. And when you call hospice, you're just going to tell the reception that you're the hospice volunteer for the patient's name and that you need to speak with a hospice manager. It's always good to keep the caregiver's cell phone number on you if they have one. For any reason really, but certainly in an emergency, to call and let them know what you have just done and why you've needed to call hospice. And what actually happens after you call hospice, the reception will get that message to the patient's nurse. There will be a short time frame that you will have to wait. The nurse should be calling you within about 10 minutes. She will either call your cell phone or the home phone of the patient. If you haven't heard back by the not hard back, I don't know about that, but if you haven't heard back, call the hospice number again, and the nurse will review the situation with you, and you all will make a decision. Again, if you ever have any questions or concerns, you're going to dial that hospice number on the back of your ID badge. Nursing home setting. This is when you're in a nursing home, not a regular personal home. This is when you're alerting facility staff. These are the people working there in the facility. In many cases, you're going to rarely need to call hospice, as the nursing home staff can attend to your needs. So some of the reasons, again, would be if a patient needs assistance to the bathroom, walking, getting into a wheelchair, always ask for assistance. If a patient falls, appears to be in pain, you see some changes in their condition or some possible changes that signify active dying. Often the quickest way to get a response is to go directly to the nearest nursing station and ask to speak with the nurse. But sometimes they're very busy, and if it's less urgent, feel free to just press the call button. And the response time you should be expecting is the facility staff member should respond to your call with about 15 minutes. If you haven't received a response in that time, go to the desk and ask the nurse to repeat your concern. If facility staff is unresponsive after another 15 minutes, that's a 30-minute total after the first request, please call hospice and tell them the situation and that you've been waiting for 30 minutes, and hospice will inform you of any next steps. You won't be having to do anything. It's just a matter of what would be an appropriate response time. Nursing home setting, when to call hospice. So that's different than the facility. When we really want you to call, again, those would be if the facility staff is not responding to pain or other significant concerns for the patient after 30 minutes. If the patient condition changes really quickly and significantly, first tell facility, then call hospice. A lot of times they will call hospice, but it can't hurt to make 2 calls. Again, if they seem actively dying, or very rarely, has it only happened once in my time here, a patient dies in your presence. Again, when you call hospice, announce who you are and who you're visiting and what the situation is. You are not required to stay beyond your scheduled time. It may be a chaotic situation and you feel, like it's your responsibility to stay. It is not. We will not be holding you accountable to that. And in the case of a facility, you don't need to contact the caregiver. The facility or the hospice will make a call, especially if that patient passes. Again, it's a little different in facility. Once what will happen after you call hospice staff are not always sent right away because sometimes the facility themselves will contend with all the issues that might be going on, and the facility will keep hospice informed of the changing conditions of the patients. But they will be sent immediately if the patient's symptoms and pain can't be controlled by the facility, or if the family requests them to be there. So don't expect that a hospice staff member will come immediately just because you called. Oftentimes the facility will deal with the situation. If a patient dies, again, a hospice staff is not always requested to come to the facility when the patient dies. The facility RN will likely tend to the patient and call the family. However, if the family requests, hospice staff will come. All right, this is our last section. If you're moving on through this and you've reached this section, you probably are then planning on attending training, and this is part of the training. Patient rights and privacy and ethics. Just to let you know that there's a patient bill of rights. A lot of these things you probably have known of. Maybe you've had to go to hospital or been to the doctor's appointment. So some of this will sound very familiar to you, but I'm trying to outline it in a way that it makes a little bit more sense regarding your work as a volunteer and the importance of confidentiality. But just to know the patients do have rights. There's a patient bill of rights, which we give them upon entering hospice. That they have a right to participate in their care plan, to have decisions. They can decide on their frequency of the visits of the nurses and the social workers, and to be part of the agreement as to what disciplines will provide their assistance. We don't force certain disciplines on patients. That is their choice. They have a right to information about their diagnoses, risk factors, if they need language interpretation, any records. They're able to review their own records. They need to know why they're being discharged. And of course, good care without discrimination. HIPAA. You've heard it 1,000 times. It means Health Insurance Portability and Accountability Act. It was originally passed in 1996. And it basically is it's a fundamental right. They wrote it so that the individual has a right to control their personal health information and not have that information divulged or used by others against their will. HIPAA, you think of it as just medical information, but it really does address every piece of health information, which we will go into a little bit more detail. Pretty much, unless required by law, all communication about healthcare matters between the patient and the caregiver is protected. This is a list of the protected health information. Some of these may surprise you. Some of these will probably be obvious, but this is all the information that's listed is the kind of information you will need to keep confidential as a hospice volunteer. So take a moment and look at those. To make it simple, here's some everyday examples of what that might look like in terms of protected health information. So of course the patient's medical record, which you won't really be privy to, but there will be times when some of their medical conditions will be shared and briefed with you as much as you need to know to provide them good volunteer service. Any patient discussions during our care team conferences, or if you attend any of our meetings, all information that is shared there is confidential. Or sometimes we have volunteer gatherings or other things where we're talking about our patients. Again, those are confidential settings. Anything that may need to be faxed or emailed, we do, as a volunteer, use email a lot. And in training, we'll talk about it more, but we ask that you use initials and try to avoid too many protected health information This will become a little bit more clear in the full training. Voicemail messages, that makes sense. And another thing to be aware of is conversations in public places. Trying to keep that to a minimum and find a private place to discuss any of your patients with your volunteer coordinator or hospice staff. Confidentiality. Obviously, we've all heard about it. It's our professional obligation. It's our way of protecting health information, safeguarding it from unauthorized disclosure. Home health care providers, these would include the hospice volunteers, have an obligation to maintain confidentiality of the patient's protected health information. We do take this very seriously. The following types of information is considered confidential. That is the information that is spoken, information that is written, and also information that is entered into computers. That could be email, databases, and that also includes social media. Continued on confidentiality, in terms of what information can be shared. Sometimes as a volunteer you may want a lot more information and you don't get it because the information that I can share should be limited to the minimum amount required to accomplish the purpose. So I will share with you as much as I feel is appropriate for your service as a volunteer to that family and that patient. If there comes a time where you feel like you need more and it seems that's helpful, we will get more information to you, but we'll start out with basic summaries of the patient and their needs to start out any patient referral for you. There are times when disclosure of patient information is allowed, and that is even without the patient's prior written consent, and that would be for purposes of treatment, for payment, like Medicaid, Medicare, or any kind of billing, and then also our healthcare operations. Just to remember that before sharing anything confidential, we must obtain a patient consent form. And you need to remember that too as a volunteer before sharing anything beyond, something very simple, and that you will also have to get a patient consent form. There's a little bit more information about the principles related to that. If you have any questions about confidentiality or unsure, you can refer anyone wanting information about your patient to our compliance officer or the HIPAA privacy officer, and they can decide whether that person can receive information about that patient's medical condition. But basically, if you aren't sure, don't tell. And the government actually does say that there can be a breach or a violation of HIPAA, and you can have a small fine, you can have spend prison time, they'll withhold our Medicaid funds. If we have a volunteer or staff member who violates HIPAA, we do have to self-disclose that, and sometimes there is a penalty. So please remember that. And then these are just really simple actions that help maintain privacy. Again, remembering those things that you're telling, speaking, writing, or entering into your computer is protected. To remind you to find a private place to discuss your patients. Sometimes the volunteer coordinator will call you at home or at work, and to be careful about that. Any friends or family that seek protected health information from you about your patients' visits, let them know you're limited in what you can share due to HIPAA. If they ask, you can say, I can neither confirm nor deny. You can say HIPAA. You can have a sense of humor about it, but just let them know. I ask you to try to use the initials of the patient in email exchanges. If you make a mistake a time or two, that's fine. I'll remind you, but that's how we do it. Please do not post, share, publish any written stories or reflections with others before first checking with visiting nurses' compliance. Oftentimes there are going to be some confidentiality breaches. Again, don't post pictures or written details about your hospice visits on social media websites or emails. And be sure to try to remember to shred or tear up any protected health information that you may have written down, and to delete your emails when they're no longer needed for contact information. And it's pretty simple. Just don't share. If you aren't certain, it's totally okay. Always check with me, and I can put you in touch with anybody that you may need to talk with. Again, keep it confidential. In our hospice volunteer training, we will be discussing these privacy dilemmas. So I'm going to leave you a moment to read through. There's 3 of these here, and decide what you might do. And then as a group at the training, we will have a little group discussion on these further. So I'm going to be quiet for a moment while we just read through these. Here's number 1, number 2. And number 3. Ethics. There's not much you need me to tell you about this. It's basically a set of moral principles and values. All health organizations have ethical principles, and they have ways of dealing with dilemmas that they may come in contact while serving patients. To know that we do have an ethical board, and we will discuss issues as they come up. These are our forums for dilemma resolutions. Again, our IDG, or interdisciplinary group meeting weekly. While we're discussing patients, there's a lot of skilled staff there who may have other opinions or ideas, and sometimes most dilemmas can be resolved through that group sharing. We can also have special volunteer, if it's through you, or it could be staff, case conferences, or staff and patient case conferences. We also have ethics committees that help resolve problems. And these, of course, depending on how deep that ethical situation may go, the people that we reach out to, that will deepen. So, I know it's a quick segue, but I know it's a lot to think about. If you've read through all of this, you probably are on your way to joining us for the Hospice Volunteer training, which we are very excited to see you, and you'll be getting more information about the dates and times of that. The thing you always need to remember is that we're a great team here, and we really do get along, and we help each other quite a bit and support each other. And we are also there to support you if you have questions or need a concern met. You're going to be reminded of your volunteer responsibilities. Don't worry, you're not going to have to memorize this entire PowerPoint. It's okay. Mistakes are going to be made. I just request that you have a willingness to learn and accept the guidance. That's really all the remedy you're going to need. You need to not be afraid to ask questions. As you get more comfortable, it does take time, but as you get more comfortable with your role as a volunteer, your experience will deepen, and in time you will likely find great purpose in this service to our hospice patients. It just takes time. It doesn't happen on that first visit, sometimes on that second visit, but in time you do meet families that you deeply connect with. It's always great to keep an open mind, be flexible personality. A sense of humor is great. You wouldn't think so, but it's so important. And really important is the ability to set aside your needs for the needs of our patients and families during the time that you're providing the care. Myself, or if somebody else is doing it, the volunteer coordinator is going to help you make good decisions and provide you with any of the needed guidance or contacts that you need. I'm going to listen to your needs. I'm going to listen to your concerns. If you have specific boundaries, I will honor those, because I know that not every patient is for every volunteer and vice versa. And so I'm going to make every attempt to make your volunteer experience beneficial and fulfilling for both you and the patient. At the top of this recording again is the information about hospice. It has our address, our website. It also contains my full name, email, and phone number. If you would like to call and have any questions or wish to apply or attend the volunteer training, give me a jingle. I hope this has been interesting at some level. Thank you. Bye.
Well, I'll tell you a little bit about what palliative care is. So it's kind of one of those weird things people keep hearing about. What's palliative care? What's palliative care? Really, we started palliative care within Mercy maybe about 8-10 years ago, but just on the inpatient basis. And about 5 years ago, they decided they wanted to do more outpatient. So they hired me. So what I do is I go around to homes, to nursing homes, to assisted livings to help with the palliative care thing. So I think what they felt was very beneficial if I could talk a little bit about what palliative care is, what the difference is between hospice, because that's always, people get that muddled all the time, is where's that line between palliative care and hospice. And then we'll talk a little bit about how the volunteers have been so useful with lots of my patients and how, and what I'm looking for when you guys are working with them too. Like Mary said, I've been a nurse for a long time. Long time. I've been at Mercy 24 years, but then I decided to go back to school. And I've always worked with people with chronic illness. People who are elderly, people with heart conditions, people with cancer. I also work inpatient rehab, so I work with people with strokes. So my whole working life has been with chronic illness, which when palliative care opened up, it kind of fit right in. Because basically what palliative care is, we work with people who are chronically ill to talk about a few things, but one is symptom management. How do we keep your symptoms in control to keep you out of the hospital? And the second thing is, what's your goals of care? We'll talk a little bit about that towards the end of the session, about how we decide what people's medical goals of care are. So palliative care, changing the landscape of healthcare. So why is it so important right now? There's a lot of people with serious and chronic illnesses, and you know, as our age progresses, there's more and more people coming up with chronic illnesses. But also you'll find is, anytime, if anybody's been in the hospital, or if you haven't, there's multiple providers in your case. If you've ever been in the hospital lately, you might have a pulmonologist, a cardiologist, a hospitalist. It goes on, and there ends up to be 3 to 5 different people involved in your care, and you're not sure if they're all talking to each other. So one of the things that palliative care does is try to help be that middle person to say, well, Dr. So-and-so is saying this, Dr. So-and-so is saying this, well, what do you want to do? More and more people are finding there's poor communication with the family members or with the patient. And Mercy is no exception. I think hopefully they're better than most hospitals, but you'll always hear, I'm not sure what they're doing. I'm not sure what I'm still doing here. What are they working on? Lack of realistic prognostic information, and meaning that there are people out there that might have a cardiac condition called a cardiomyopathy, and they're like, well, how long do I have to live? Or you have people who have an end-stage terminal disease, not ready for hospice yet, but they're all trying to figure out how long do they have to live. So how can we help guide them to say, these are the signs that we look for along the way. Lack of clear medical goals. And we also hear this a lot too. I got discharged too early. Well, the hospitalists probably met their goals, but they didn't know what your goals were to meet them. So meaning that we're looking for, what are your goals to get out of the hospital versus, or to continue on living at home versus what the healthcare for people's goals are. Poor pain and symptom management, and we're trying to get better and better and better with that though. Because now we really don't want somebody to be in pain. So if they start to have some pain, how do we control it? If they have some shortness of breath, how do we control that? But it's trying to get their symptoms under better control, because we know if the symptoms are under better control, your quality of life is better. So the key is, what's the quality of life? And again, I talked about patients discharged quicker and sicker. Medicare doesn't let us keep people for 3 or 4 weeks for, 30 years ago. Even childbirth, 30 years ago, you could stay for 5 or 10 days, as now it's like a 2-day stay. Why the need for palliative care? You see the number of adults over 85 are going to double to 10 million by 2030. Average 75-year-old has 3 chronic conditions and uses 5 different prescription medicines and multiple over-the-counters. I do a lot of looking at people's medications list just to see What are you on? What could be interacting with each other? What could be causing you this? What do you have to take consistently to keep you out of the hospital? And it's abnormal if you have somebody with 3 or 4 medicines. So if you're one of those people that has 3 or 4 medicines, count your lucky stars. And then also, death is not predictable for patients with chronic illnesses. Like we talked about before, if you have COPD or a lung condition, nobody can tell you what your life expectancy is. You just look at what the factors are, that the prognosticators. Healthcare reform. You know, healthcare has been struggling because we've been rapidly changing. Patients are more critically ill. There's a lot more increased outpatient care. So there's a lot more people being seen at home or in the offices or outpatient surgeries. Again, patients discharged sicker and quicker. And then there's this new thing, I don't know if you guys have been hearing about it, but starting in October, Medicare is now penalizing hospitals if they discharge a person and they come back within 30 days. So, yeah, they're finding all kinds of ways to like make sure that we're not going to make what we did 5 or 10 years ago. So meaning, if we discharge somebody, we better make sure they're pretty well to go home, and we really want to keep them out of that 30-day window. So part of my job, too, is when I go see people at home is how can we keep you out of the hospital? I prefer for years instead of just the 30 days, but that 30 days is a good way to start. What do the people want? You know, you can see this. Consumers are asking for higher standards of care. We're becoming much more, I always think about this because, again, I've been a nurse forever. I think about how savvy patients are now, and patients and family are. They're much more demanding of good care and of efficient care and everything going well, and asking questions. Where, when I first started nursing, 30 years ago, probably shouldn't date myself that much. 30 years ago, people, you'd say, what's your doctor saying? I don't know. What medicines you taking? I don't know, I just take the ones he prescribes me. People are savvy now. They know what their medicines are and they know what they want. Well, they also want vigorous treatment for their pain and symptoms. Again, it goes back to that quality of care. Relief from worry, anxiety, depression. And if you go to, and you guys know this, you're the volunteers that go in and see these people. If you can help the worry and the anxiety and the depression, that's a lot of the battle, just to make people feel comfortable. They want communication about their care over time. They're just not going to just sit back and let people do things to them. They want a coordinated care, and throughout the chronic illness, and the key with that is, chronic illness isn't just like a hospitalization that's 3 days long. It's something you're going to have for years and years and years of your lifetime. So you don't want somebody to just come in for 3 days and not know what's going on for their lifetime. They want support for their family caregivers. You know, and you know, again, this, as you see your patients who are in that last stage of life, they're saying, I want my husband to be okay. I want my kids to be okay. Practical support, not utopia, what's pie in the sky, but what's practically can support to help them stay at home. And then they want just a sense of safety within their healthcare system. You know, we hear a lot about medication errors and treatment errors, but they just want safety. So I'm going to talk about I'm going to define palliative care and hospice care, and then I'm going to show you a slide that talks about what's the 2 different populations. So palliative care, specialized care for those experiencing serious, chronic, or life-limiting illness. The goal is to relieve pain, symptoms, and stress of serious illness to achieve the best quality of life while supporting patients and their families regardless of treatment goals and life expectancy. So regardless of treatment goals and life expectancy. That'll be key in just a little bit. Hospice, comprehensive set of services coordinated by an interdisciplinary team to provide for physical, spiritual, emotional needs for the terminally ill patient and their family members as delineated by a specific patient plan of care. So when it comes to what's the difference between hospice and palliative, sorry if I get in front of that, let me know. So palliative care, we can work with people under any stage of their serious or chronic illness, okay? Second point, and compared to hospice people, it's going to be the dying patients of any age. Palliative care services are provided throughout the illness and simultaneous with other treatment. And patients do not have to forego curative treatment. So that's the big thing. Patients that I have, like I have a lot of cancer patients, they're starting out they're either starting out in their treatment, in the middle of their treatment, they're still doing radiation, they're still doing chemo. That's okay. In palliative care, you can continue doing your treatment. By the time they get to hospice, radiation and chemo aren't on the table anymore. That's probably the big thing. At hospice, services provided end of life when curative treatment is not desired nor effective. Under palliative care, there's a team focus, hospice care, team focus. Focus on the quality of life and decrease suffering. Palliative care, team coordinates the care from a variety of healthcare providers, specialists, primary care, prevent fragmentation of services. Agree to be kind of that core to make sure everybody's on the same page. Under hospice, coverage includes team services, medications, equipment, supplies needed for terminal illness. Palliative care, under reimbursement, how we get reimbursed for palliative care is the physician can charge, the nurse practitioner can charge, the licensed social worker can charge, but we can't charge for our social workers or our nurses. Where on hospice, they get paid a per diem rate, and they get paid for, they get that per diem rate for all their services. So it's reimbursed by Medicare, Medicaid, and insurances. So if we're talking about who should be considered for a palliative care consult, anybody who has pain, trouble breathing, or any other distressing symptoms. It can be depression, it can be anxiety, anything like that. Our social worker is very good at those. Anybody who's had frequent emergency room visits and frequent hospitalizations, because you'll see, I'll get people and I'm like, you've been in the hospital 3 times in the last 6 months, doesn't that get a little old? They're like, yes. It's like, okay, so let's figure out what's the plan to keep you out of the hospital. Psychosocial or spiritual issues, serious illness and facing questions about the future. We have all faced that, even with your hospice patients too, of what, that part of that anxiety is, what's the future hold? I don't know what to plan for. How do I plan for this? And the need for clarification of treatment goals. We'll talk about that in a minute too, but talking about code status, tube feedings, ventilator. If people have questions about what they want for their health care, then we look at that. So when we talk about that code status and feeding tubes, we do that a lot with inpatient and outpatient. And we do something called an I-post, and I can show you in a little bit, but it's an Iowa physician order set for treatment. We're doing it used to be Lynn County and Jones County were 2 counties in Iowa that were piloting it, and now about 3 years ago it went statewide, so all the counties in Iowa do this I-post. And what it's meant to do is for people to decide what their healthcare wishes are when they still have the capacity to make that decision. And we talk about basically 4 big things. We talk about if your heart stops naturally. Do you want to be able to pass naturally, or do you want somebody to try to start your heart up again? It's amazing to me that, and I have people who are 90, 95-year-olds saying, sure. I'm like, it hurts. It hurts. You might not be able to stay at home. Your brain might not function as well. And just the big thing is just give them the education. It's still their decision, whatever they want to do in the end. It's not up to me. But if all these factors are in consideration, if your heart stops naturally, do you want to be able to pass naturally or have somebody start it out? The other question we ask is, if you had something that you needed to be on a ventilator, would you consider a ventilator for 5 to 7 days? Okay. Would you never want to be on a ventilator? The problem is if you go on the ventilator a little bit, you might end up on the ventilator for the rest of your life, and then your family has to make that decision when to take you off the ventilator, which is a very difficult decision. So we talk about what do you want for if you have to be on a ventilator. And they'll be saying, well, I'll do it for a few days. All right. Then just understand that your family, and your family's usually always sitting there. Just understand the family understands that after 5 to 7 days, if you're not doing well, they'll have to make that decision. And then as long as everybody's on the same page again, it's okay. The third question we always ask is, so you get pneumonia, you need to come into the hospital, you need some IV antibiotics. Are you okay with that or not? Majority of the people are saying, yeah, I'll come in the hospital for a little bit of time. As long as those antibiotics are going to work. There's just a small minority, and those are the people who are either really chronically ill or they have a bad dementia that the family's deciding for, and they'll say, no, we just really want no more we just don't want comfort measures. We just don't want anything more heroic. And again, that's legitimate too. Fourth question we always ask too is, if you had something like a big stroke and you couldn't swallow anymore, and the only way they could feed you is through a tube in the nose or tube in the stomach, would you be okay with that? And again, it's kind of up in the air what people usually choose. Some people will say never, And then some people will say, I'll do a tube in the nose for a little bit just to see what happens. And again, the whole thing is to make sure that your power of attorney for healthcare is on your same page to be able to follow through with your wishes. So we do this so when they have the good capacity to make that decision, it's the smartest time to talk about it. And I always tell people, that's exactly what I would have put down. So I need that.
Johnny,
Yeah.
even if you have this healthcare, you still have to ask those questions. Like if yours says do not resuscitate or do not put in a ventilator, you still have to ask those questions.
So if your advance directive says that, yeah. So what the nice thing about this one, this iPost, is it is in a form that you put on the side of the refrigerator. So if a 911 is called, they can come and see this. Now, yeah, you still have to ask. It's a kind of a more of a safety net so that people don't do what you don't want done. It's right there on the side of the refrigerator. They know to look at it. But as long as your power of attorney knows what you want done with no resuscitation and no ventilator, then that's okay. It's a good thing. There's multiple ways to tell people what you want done. That's a good way, and the iPost is a good way too.
Could I have an iPost in my refrigerator?
And they used to say it has to be for those people who are really chronically ill, as long as you have a chronic illness. But more and more people, when they're well, are doing them, which kind of makes sense to me. And you can always change them. I tell people all the time, this isn't written in stone. I mean, if you tell me in 6 months you want to change this, we can change it. It's not, it's not a problem. Just want to know what's happening now. But more and more healthy people are getting it done too. But it's typically for the older.
Does an iPost have to be notarized?
No, it just has to be signed by a physician or a nurse practitioner. It doesn't have to be notarized. It's a good question though. Palliative care focus. Patient and family is a unit of care, the whole person care. We talk about communication, there's an interdisciplinary approach, and education is a big part of that too. So it's very like hospice that way. People I work with a lot, basic lung disease, like the COPD, people with COPD. Maybe they have an advanced cardiac disease like congestive heart failure or coronary artery disease. I have a lot of people with cancer that are like metastatic or recurrent cancers. End-stage renal disease, it's always a tough one. The people on dialysis is trying to help talk to them about where's that line in the sand? Like, when do you really want to go off dialysis? Because we know that once you're off dialysis, it's not too much longer before you'll pass. So where's that line in the sand? It's usually those people that are in the hospital a lot, they have to go to the nursing home, they don't feel this is a quality of life, and then they decide when they want to go off. Stroke with decreased function, a lot of people with dementia, and it's usually that end-stage dementia. The weird thing about Medicare is they have a real strict guidelines about what patients they can accept into hospice, and it basically is people who aren't talking and people who aren't walking and people who aren't eating. Then Medicare says, okay, they're hospice appropriate. But there's a middle stage in dementia that's very hard for the caregivers to handle. So we work a lot with people with dementia. Lou Gehrig's disease is that ALS one, and then MS. Any serious accident, any other life-limiting or chronic illness. Palliative care, where hospice can't work with people on a skilled nursing facility, like if they're doing rehab. Palliative care can work with anybody about any area. We work in hospitals, we work in long-term care facilities, we work in skilled units. I go to Hallmar a lot. I work at home. Home is my primary place I go see people. I can go to the physician's office if I need to, if like they need another person. If I know I'm going to pick them up, the oncologist will come and say, can you come meet Joe Smith at 2 o'clock today? We're going to be meeting with them. So at least we can transition from that smoothly. What studies have found, consumers may be content with the quality of health care they receive. They have concerns about the level of care of patients with serious illness. And the biggest concerns are related to communication and control over what their treatment options are. This is hard to read. Biggest concerns for patients with serious illness. The doctors might not provide all the treatment options or choices available. They might not talk or share information with each other. That's 55%. Doctors might not choose the best treatment options for a seriously ill patient's medical condition, 54%. I mean, it's amazing the people you say they're 94-year-olds and they're getting a pacemaker. It's like, okay.
6% what people believe, or is that what actually
Oh, sorry,
happens?
people believe.
Okay.
Public opinion, yep.
Okay.
Patients with serious illness and their families leave a doctor's office or hospital feeling unsure about what they are supposed to do when they get home. 51%, people with serious illness and their families do not have enough control over their treatment options. And I think if we do anything in the next 5 or 10 years, it's shifting that focus for people to take charge of their own health care. And that doctors don't spend enough time talking and listening to patients and their family. And we all have those people that we know that would sit with you for 20 to 30 minutes and would give you their right eye, or you would have the doctor send in 3 minutes. I mean, we know all those people. We talked a little bit about that I-post. It just makes healthcare wishes known while you still have capacity. So this is that I-post form, but it's like a salmon color. So it does things like that cardiopulmonary resuscitation, what's your decision? Medical interventions, if you want to be comfort measures only, or if you want full treatment. Artificially administered nutrition, that's the feeding tube. And then once those 4 questions are asked, the 4 questions is in B, it's either your comfort measures only, or would you want to have a ventilator, or it's okay to come into the hospital. And then we sign it, and then the person signs it and I'll sign it, or the doctor sign it, and then we just give it to you, the original, and say, put it on the side of your refrigerator. If 911 comes, they're going to look there first and then take it to the hospital with you, because that will be how your health care wishes are spelled out.
Does the doctor have a copy of that on file?
No, we can't make copies of it, but it's in the notes. And the interesting thing is we do a computer system at Mercy called Epic. And they're just telling me within the next 2 to 4 months, they'll have a banner, it's called a banner, that will have the I-post on it, the I-post wishes on it. So that should get even easier for people to follow. That's what we're hoping. Okay, so volunteers in palliative care. So probably, I don't remember, Mary, maybe 2 years ago, maybe more than that, 3, doesn't matter. We were seeing that we were going out to see patients at their homes that would be very successful living in their homes if they just had a little bit of a safety net. You know, just somebody to make sure that they're doing okay. So Mary was gracious enough to allow you guys to work with some of our patients. So if I go into somebody and I think of my favorite patient, Margie, just a couple years ago, lived by herself in an apartment, and she, her daughter lived in Kansas City, her boys weren't around much, they lived farther away, but she just needed somebody just for a little bit of socialization, somebody to talk to, somebody to just be, because she was pretty isolated in this apartment. So what Mary agreed to is that a volunteer would come twice a week, I think, to help her out, and it really was exactly what she needed, because it gave her somebody else to talk to, somebody else to voice her concerns to. And it's also, you guys know this, it's nice to have another person to bounce your ideas off or to get some solace from, so that they feel more comfortable. So what I usually tell people is, okay, we have this opportunity to have some volunteers to come in. So as we're asking questions about what would you want? Somebody to talk to me about current events, somebody to read the newspaper with me, somebody to just go outside and walk outside with me. There's lots of different ways to use you guys to help with those people. Then what I also just say is, typically it's going to be somebody who's going to convert into hospice eventually, which is the nice thing is that we talked about is when they do convert in, then you guys keep the same patients, which is wonderful for our families to know there's that same face going from palliative to hospice, because they've got a lot of changes going on with their staff, but that hospice volunteer is the consistent person. I have Earl in Hallmark, he's one of my guys, same thing. What do you want, Earl? I mean, Earl's very bright. I just need somebody to talk to with, or converse with, or go outside, whatever. So it's been a very nice match. And even the people who've converted from palliative to hospice, it's been very nice. So that's how when Mary asked me to talk to you guys about palliative care, I said, yeah, you guys have given your services to palliative. It's, we can sure respond back with just giving this little presentation. So that's how I just want to say thank you very much, because it's a nice benefit for our palliative patients. If anybody wants anybody, if you know somebody that would benefit from palliative, it just has to, the physician has to refer it. And so it's to cure sometimes, to relieve often, to comfort always. So that's the basics of the presentation. What questions does anybody have?
This is a brilliant group, so I'm.
Brilliant. Yeah.
I'm curious as to how the hospital is penalized if they send a patient home and they return before 30 days.
So don't ask me the exact percentage, but what they'll say is, so say somebody goes out with lung problems or congestive heart failure, it doesn't matter what. So they leave, and with 30 days they come back with congestive heart failure again. The Medicare says is, you didn't take care of your patient right. So they came back. So we're going to pay you, don't quote me on the exact percentage, 50% of what we would have paid you before.
Oh my gosh.
I mean, it's not, it's the 50% is probably generous. It's probably nothing. It's something they're docking it tremendously to come back. And they'll say that. Now, if that congestive heart failure person comes in for a total hip, within 30 days, doesn't bother us. I mean, that doesn't affect us. It has to be the same diagnosis within that 30 days. Isn't that funny?
Now, who refers the patient for palliative care?
The physician, because it can be inpatient physicians, it can be their primary care physicians, it can be their oncologists, it can be their pulmonologists. Yeah, it's usually the physician or the primary provider.
Because as I look at everything about palliative care, and I've had friends that have been in the hospital that have had palliative care at Mercy, but for example, I have a neighbor who, a little bit older than I am, was just released from the hospital, and her family thought she probably should have gone to the nursing home, but the decision was made that she should just go home. So she went home that afternoon, and that night the ambulance was back and took her back to the hospital. So see, she would fit under that area. But yet the thing of it is she could really qualify for a lot of the offerings that you have with palliative care at home.
Yep. Yeah.
You know, she has a husband who doesn't cook, doesn't know how to do anything at home.
Yeah.
You know.
So he's got a Y chromosome, huh?
Yep.
Yeah. No offense. No offense.
But anyway, so I'm saying, so now the hospital will be penalized for that. Now she's not going to get out for 2 or 3 more days, and now she is going to the nursing home.
Yeah.
So.
And what Medicare says, they should put her in the nursing home, should have gone to the nursing home first. But what she probably said, I don't know if that's what she said, a lot of people will say, I'm going home. I am going home. And you'll say, okay. The nice thing is if we have home health involved too,
Right.
within 30 days of home health, if somebody's involved and they have to go to a nursing home and not come to the hospital, Medicare's okay with that. They give us like a little window, but that ambulance ride back and staying overnight isn't one of the options. Yeah.
In debates over physician-assisted suicide or doctor-assisted dying, one of the more common arguments against legalizing it is that palliative care has come such a long way that it's rarely necessary anymore, and that people who think they want to ask for doctor-assisted dying end up not wanting it after they're given adequate palliative care. Is that a view you share?
Oh, seriously, for sure. I went to a talk to the Hemlock Society a few years ago, who were not very kind to Catholic hospitals. I had to keep my mouth shut for a little bit because it wasn't going to come out Christian, but I kept my mouth shut. But that's exactly right. And that's exactly right. It used to be a lot of doctor-assisted suicides because that person with ALS couldn't die on their own. I mean, people would continue making people live because that's what we're supposed to do. We have the ability. We can give you antibiotics for 2 months, but it's not going to change your outcome. Or we can put you in a wheelchair, but now with palliative care or people getting more choices for their own health care, it really has curbed that. That was a good point, though. That's exactly right. And it's all about what your wishes are. What do you want to do? We all have those wishes. It's just getting that out and making sure people understand them. That's a great point, though.
Just a remark to that lady's question about who orders the palliative care. If the doctor doesn't, it's not like it said you can't talk to the doctor and suggest it yourself and say the reasons why and you know, I don't know how close you are to those neighbors, but like if it was a family member and you have this knowledge and the doctor hadn't brought it up, you could say, I think mom or my sister or my uncle
Could benefit from
palliative
Mhm.
care, and maybe these
Exactly
are
right.
even the reasons why.
Yeah,
Would you agree, doctor?
we get more and more on
Not
that.
he can be the only one or she that can
Yeah.
bring it up.
Oh, no, no.
If you have knowledge of it, it's very much your place to discuss it with him.
Yeah.
But he has to order it.
Yeah, and you're right, a lot more people are saying, I want my mom to have palliative care. And the other nice thing about even physicians is what they'll do is they'll bring palliative care to do outpatient stuff, to do nursing homes, to not wait, but to monitor and keep symptoms under control. But once that person starts to decline, is now to be able to, I have a lot of people with cancer, and you watch them for months and months, and all of a sudden they're starting that decline, which is going to go pretty rapidly. I have the tincture of time. I can sit down in their home at their dining room where they're least nervous and say, all right, here's what we're seeing as those signs that aren't boding well for you, that means that the cancer's progressing. Now's the time to get hospice involved. And then that's having that open discussion about, what's hospice do? Are you sure? We want to live? I mean, there's so many different questions, but then you're able to sit down for a longer period of time than what the doctor has in the doctor's office, which helps out tremendously.
I can see a huge benefit where that, you know, for people who are going through that general slow deterioration, for them to be brought along gently in the
Oh, yeah.
hospice rather than one day I'm fine and the next day I'm on hospice.
Yeah.
So it causes a lot of confusion for the
Yeah.
family, and so your
Yeah.
advice and your collaboration with the family probably brings them along.
Yeah, and I started right at the beginning. This is what we're going to do. We're going to do this. But when I start to see these signs, we're going to talk about transition to hospice. So it's not like it's a surprise for them. Exactly right, over time. And then the day they'll call me and say, this is happening, I'm like, okay, now this is what we were watching for. Now's the time to transition to hospice. So it's much smoother to have that constant person to kind of help guide them through that.
So if you're on palliative care at the hospital, and then you're released from the hospital, does that follow?
No, not all the time. It's
Okay.
very individual. So if the inpatient staff says, oh, these people really need outpatient palliative, they'll get the order from the provider.
Okay.
And then, and that's another thing that the family can always ask for too. So not automatically. And it's kind of what those frequent hospitalizations and maybe a stage 4 cancer diagnosis, they'll make sure we're involved in.
How many of you are there?
God
Say
only
that
made one.
You're chasing off after
Yeah,
this patient
yeah.
and after, you can't be doing it at all.
No. So the nice thing is that inpatient staff has two full-time nurses. They have a social worker, and then Dr. Sirlock, who's our medical director, is there half-time. So that's the inpatient staff that can go cover the whole hospital. For outpatient, it's me, and then I have a social worker with me that does a lot of that. We do just go bounce back and forth on each other about, she'll go see somebody one week, and if she sees something that's not right, she'll call and say, hey, I think this person needs a quicker visit. So there's two of us, but really, if you think about it, we do okay, because we do have that transition out. For those people that transition, either they get discharged because they're okay now, you know, they've been out of the hospital for 6 months, they're really clicking on their cylinders, they don't need us anymore, we back out. Or if it's those people that transition to hospice, and then occasionally we have people that pass within our palliative services, and usually it's the people say, I don't want hospice. I'm like, you need hospice, but that doesn't happen very often, but every once in a while we have people that pass within palliative. So really, it's like, I think there's probably 80 to 90 on my caseload, but it's fine, because some people I see once a week, some people I see once a month, some people I see once every 3 months, the stable ones.
There are 80 to 90 people that she keeps
Mm-hmm.
having. Okay. You and this other person?
Mm-hmm.
Okay,
Yep,
thank you.
not a problem though. You do good, not a problem. Yeah, I'm not overworked. I'm behind on my notes, but I'm not overworked. Can you delete that? Yeah. Any other questions?
When you went back to school, where did you go and what did you get?
So I've been a nurse since 1984, and I've always done rehab. So that means I work with people with strokes or brain injuries or something like that. So then I ran a memory disorder clinic with a neurologist in town. So I had all these chronic illnesses. So then I decided, well, I'll go back to school because I wanted to be able to, you know how you see people be able to just make decisions right away, and they can write this prescriptions, and it's done. I think, God, it'd be so much quicker if I just could write prescriptions. So I went back to school, but I think I was 42 or something when I went back to school. It took me 4 years or so to get to school. So I went to Allen, and I got a nurse practitioner degree, family nurse practitioner. Yeah, but my love is always chronic illnesses. I really had never wanted to see a kid in my life. To this day, I don't want to. Well, so that's why when palliative care popped up, I'm like, this makes perfect sense, because I understood what chronic illness was about.
I didn't know if there was a specific
No, no. You can get your certification in palliative care, which I got a couple years ago, but hospice and palliative care. So I got a certification, but I've got quite a few initials than I need. Any other questions? All right. Well, thank you very much, guys.
Thank you.
Yeah, no problem. Thank you.